palliative care is really focused on making every day the very best day possible. Because if a family has life-prolonging goals that they want to live as long as possible, they also have a goal of comfort. And so many of these families feel like they're stuck, and it's our job to be with them, to accompany them during these really complex times. It's very common, though, that many families and frankly many clinicians still think about palliative care as about being exclusively about end-of-life care. But palliative care is so much more than that.
So how have you seen the level of care and care plans change today?
Welcome to the Digital Legacy Podcast, where we talk about death and dying in the digital age. If you ever asked, how do I protect myself and those I love if something unexpected happened to me? You're in the right place. I'm your host, Niki Weiss, and together we'll explore how to protect yourself in a world where both your physical and digital legacy leave a lasting impact.
And welcome back to another episode of the Digital Legacy Podcast, where we talk about death and dying in the digital age. My guest today is Dr. Justin Baker. And Justin, I got introduced to you because you were one of the main presenters at the Endwell conference this past year. So thank you, and a privilege for you to be here today.
Well, it's wonderful to be with you, and thank you for the opportunity.
And, palliative care for children, we're talking about pediatrics. And I was sharing with you that, when I tell people that I'm a digital thanatologist and specializing in death and dying, they tend to lean towards the aging process and not necessarily the reality of children are also susceptible to disease and accidents and unexpected. So what brought you to this kind of work?
Well, I'll tell you, it's such a privilege to work in the field of pediatric palliative care, and it's very clear that the field found me. I feel like God put me on the planet to do this very work. When I was going through medical school, I always knew I was going to be a pediatrician. I've always been really drawn to taking care of children. But while I was in medical school, my grandmother died from cancer, and I was working with her, and I saw the impact that the oncologists made. And as she was approaching the end of life, I thought, my goodness, this seems like such an important time. And so then as I became a third-year medical student, I started seeing all the different fields and areas, and pediatrics was my last experience. And as I was rotating on pediatric oncology, I met somebody who did pediatric palliative medicine. And when I asked him about it, he said that the field was all about making every day the best day possible and how the enemy in pediatric palliative care is suffering. And I thought, there's no way that this could be real. And I just had this light go off and really felt like at that moment, it was kind of a before and after moment. I felt like after I heard that explanation, then the next day I went and saw a patient at home. This patient's name was Jake, and I saw Jake with this physician named Dr. Kane. And at that point, it was very clear that this was the right thing for me to do and dedicate for the rest of my life.
And then the palliative piece, right? For many people, we're still educating on them what palliative means. They've heard of hospice, and even hospice, they think that is like you're taking your last breath, and that's another definition that we need to kind of unfold. But let's pull it back more so, right? So even before hospice, it's stepping into palliative. So as a physician, working with families, parents of children, and having to introduce this heartbreaking option that their child is now qualifying for palliative care. How do you start that conversation?
Yeah, I think the first way I like to think about it is that palliative care is really focused on making every day the very best day possible. In fact, you see this QOLA behind me. Our team here and our program here is called the QOLA program, which means Quality of Life for All, QOLA. And we talk about that because palliative care is all about quality of life. And as I said, making every day the best day that it can possibly be. And we try to integrate that with medical issues. We try to integrate that with cure-directed or life-prolonging therapies so that it never is an either or, it always is a yes and. And certainly what we try to do is we try to come around a patient and family and look from all different angles. from a social work lens, a child life lens, a physician, a nursing lens, a psychologist lens. We try to take this interdisciplinary approach to think of all the different ways that this patient and family is suffering, is having a difficult time, and how can we address those from all these different angles, again, to make sure that every day can be the best day possible. It's very common, though, that many families and frankly, many clinicians still think about palliative care as about being exclusively about end of life care. But palliative care is so much more than that. It really is an interdisciplinary, relationship based approach towards integrating quality of life related care. I find it very interesting too when I think about our team. Like I said, we have the QOLA team, this quality of life for all program that we've created. But I sometimes wish, when I meet families, I like to tell them this joke. I sometimes wish that we had called ourselves the Get Her Done team, because if there's something that you think could make today better, call us and we'll try to get her done. And that's really what it's all about. It's about working with patients and families, them being at the center of helping us work with them to figure out what is most important to them, what are they worried about, and how can we address these issues.
I mean, all those unimportant life activities that we do kind of fall to the wayside. And it really is just, how to embrace the moment today with the child that you have in front of you. And at the same time, normalcy. I mean, it's like trying to bring that level of like, today's just another day, what it's going to look like, who's going to be involved. But to be able to have that team, it is quite the honor. I have to say that another reason I'm very drawn to this is because when I was a hospice clinician, I actually was part of the palliative and hospice team for pediatrics. And the children and families that I served was still imprinted on my heart.
That's right. It's such an incredible honor to do this work. These patients and families teach us so much each and every day. If we really go in with a curious, open mind, and when we go in with our hearts open, many people think that our hearts are going to be broken, but instead we walk away from those situations so inspired. These patients and families address these day-to-day issues in such a inspirational way. And even families who are really struggling, that are just kind of stuck, what we try to do is we try to make every situation, even if it is just absolutely horrific, just a little bit better, because of our team being involved and trying to take a little bit different angle of approach towards addressing those issues.
And I think from the palliative team, you're probably with some of these families for a long period of time, perhaps, right? Because maybe the child is early diagnosis and they have a life expectancy. So I'm going to let you share on that one.
Yeah, many of these families, we meet them, and actually the research on this shows that from the point that a pediatric palliative care team meets a family, well, if I think about this in the context of adult palliative care or adult hospice care, the time from referral to hospice to death is very short. In pediatric palliative care, more than 70% of our patients are alive even after 1 year after meeting the palliative care team. So we know these patients and families for many years, very frequently. And it's incredible to see how our involvement across time can really make a difference. We may engage a home-based team so that we can partner with them to make sure that a patient and family is also being supported in the home setting. We might increase psychosocial support for siblings and for other caregivers that might be in the home and other family members that might also need support. Again, we try to take a big picture point of view, a holistic point of view, to address suffering in all its forms to make sure that every day can be the best day possible.
Now, you're with Stanford University, which is a large institution, but you mentioned, right? I mean, do you serve outside of your vicinity? And families do they need to come to your location? They're traveling worldwide to meet you and to work with your team?
Well, here at Stanford right now, we mostly do inpatient consultation. So it is mostly at the hospital. And we are starting next month to provide telehealth support and to provide extended support beyond the hospital walls. So we right now are starting our own clinic setting. We're also starting telehealth support for our patients and families. So we're very excited about that, because the most important thing is that we can provide this care regardless of the care setting. We really need to take that patient and family and ask them, what's most important to you and where is it most important to receive that care. And many families, they want to receive that care in the home setting. And so we're really excited to be partnering with them. We're really excited to be starting our telehealth program where we really will be supporting patients and families all across the country.
Well, tell us more about that because that really does intersect with this digital piece. So, how have you seen the level of care and care plans change today? I mean, we could talk about AI, but versus where you were maybe 20 years ago.
Well, I think that's one of the key questions going on today. And I really struggled. Pediatric palliative care as a whole struggled through COVID. Palliative care as a whole struggled through COVID. But one of the beautiful things that came out of COVID actually is such a familiarity with the use of telehealth. And I don't think there's any going back. Our provision of telehealth services before COVID were almost none. And now about half of palliative care visits are done by telehealth.
Wow.
And we do that in cooperation with local hospice agencies who may be going into the home and providing direct hands-on care. We do it as support to a family through a call tree. We also do it in proactive visitation with patients and families through our ambulatory process, which is what we're going to be starting next month. So we're very excited to begin exploring this more deeply here at Stanford. The field as a whole of palliative care has really moved and embraced telehealth. Patients and families love it. They want to receive mental health support as well as palliative related support through telehealth. So the ability to receive this care sitting on your couch at home with your child in their most familiar and loved setting really is something that we have to continue to embrace and support. And hopefully we'll get to a point one day where if a family says we want to receive all of our care at home, that we can provide that. We still have to have them come to the clinic for various things, come to the hospital for various things. But we're really hoping that we can do more and more in the home setting for these patients that we're following longitudinally for long periods of time.
And again, just to, deepen the definition of palliative, right? So when you hear palliative, it means that they're still receiving treatment versus hospice where they're making that decision not to. But
well, actually, even
can you
hospice, yeah. So interestingly, because of concurrent care, many people know this as Obamacare in 2010, pediatric patients under the age of 21 who are hospice eligible, they can continue to receive life-extending treatments and interventions while also receiving hospice-based care. This is a really core tenet of what pediatric palliative care and pediatric hospice care, of how it differs from adult care. They can receive funding to receive both hospice-based care and life-prolonging interventions. This is the beauty of pediatric palliative care and why it is really totally different than adult hospice care, for instance. In pediatric palliative care, what we really try to do is we do try to address the sources of suffering, and we try to make sure that we're attending to that suffering regardless of the overall goal. Because if a family has life-prolonging goals, that they want to live as long as possible, they also have a goal of comfort. And so we come alongside and try to help them live as long as possible while also making sure that every day is the best day possible.
My heart is like, I wish I had this conversation with some of the Alzheimer's hospice, organizations, right? Because I feel like what you're doing in the pediatrics, it's not translating in some of the, and longer term conditions that people out there, those memory care issues, because as similar, they're in the system for a long period of time.
Yeah, I really hope that one day we look at the hospice provision, which was really built for progressive incurable cancer, and recognize that those home-based resources for adults with, like you're saying, memory care related issues, dementia or otherwise, that it really would benefit us as a society to move that home-based interdisciplinary care out of a 6-month prognosis. That is complicated, of course, because it's very expensive. And at the same time, if we look at actual cost savings that could come by preventing end-of-life admissions and hospitalizations, it would likely make up a big part of that gap.
like I said, I think there needs to be a refresh. And are those conversations happening
Yeah,
at this time?
yeah, they certainly are happening. I think that it's not a great time to be looking for healthcare funding right now with all the things that are out there. And so, if you think about the provision of care through things like Medicaid, that certainly looks like it's going to be cut significantly. And so, there's not really opportunities to expand services right now. Most people are looking at how do we contract and make sure that we're giving the right services to the right patients at the right time. So I am very hopeful that in the future we can think about reimagining how hospice care, or even I like to think of it as community-based care for patients and families with significant illness or serious illness, how we can reimagine that as a medical community within our greater community. But I'll tell you right now, the medical community is really scrambling because so many of the funds right now are being stripped away from healthcare.
You just can't make this up.
Mm.
I mean, we are just in a time and moment that we just need to pause and really, we need to take an assessment of what our human equity is.
Yeah, this is why I love pediatric palliative care, because it just transcends all political issues or otherwise. And as you think about the care that we're able to provide these precious patients and their families, these youngest and really the ones that need this care the most, it's a beautiful thing because people never argue, oh, you know what, children, we shouldn't spend money on addressing childhood suffering. So it is actually a very uniting concept. The difficulty is many people don't understand that by stripping monies out of the system, that it puts all of this at risk. It puts pediatric palliative care at risk. It puts certainly adult palliative care at risk. And you're having to reconsider what are the healthcare priorities in the middle of a time when the pot is getting smaller. And so what I really love.
The pot's getting smaller, but the needs are
Of
increasing,
course.
right? I mean, my understanding is even like your program has expanded over the last couple of
Yeah,
years.
that's right. We are expanding quite a bit and we're serving more and more patients and families. And interestingly, this is something also that many people miss about pediatric palliative care is often as we're advancing our interventions that can provide life prolonging care, things like really interesting cardiac related issues or life extending interventions for genetic disorders. As we think about that patient population, that then we're extending their life longer and longer, and again, able to support them through programs like ours and in the home setting, what do we do when they transition into the adult world? This is not something that as a society we've really thought about very much. Even as a medical community, this is an area of great concern because we don't have systems ready to receive these patients. So when they turn 22 or 23 or 24, these patients with really significant medical illnesses that are childhood related illnesses, the adult medical community is certainly not ready to receive
Not
them. And
equipped.
we in pediatrics are not really doing a great job of transitioning them. And so we, again, as a medical community, really need to contemplate how do we best care for that patient population as well.
Well, I just want to roll back the conversation a little bit because some people might not be, when we say pediatric, I'm going to surmise that some people are probably thinking of a child, right? Or maybe a young adolescent. But your definition of pediatric for textbook for our listeners?
Yeah, so most of our patient population is 21 or younger, and we do have those patients that we take care of that are older than that. I mean, it's pretty common in pediatric oncology, for instance, if a young adult has a pediatric related disease, so something like Hodgkin lymphoma, or perhaps even something even like a brain tumor that usually happens in children and is not very common in the adult setting, there's a debate on where should that patient be best cared for. And it usually happens that it's within the pediatric setting because we're so much more used to caring for those kinds of cancers. So I would tell you that 21 or younger is really not a huge debate. Again, Obamacare, the Affordable Care Act established that. And we even go a little bit higher than that. But then there are groups and kind of areas of the hospital where there's real complexity. If you're talking about a 25-year-old patient and you have a whole cardiovascular approach that you take in pediatrics that's totally different than in the adult world, you might
I would think the equipment would even be different.
yeah. So things like the intensive care unit, they have to set different parameters. And so, again, when I'm talking about this transitions of care and when to move into the adult setting, it's one of those things that we're really deeply contemplating as a society right now and as a medical community.
I mean, there's so much to consider. So I just want to make everybody aware when we say pediatric, you're talking from, I guess, utero. I mean,
Yeah, we have
do you start it in
perinatal.
utero?
Yeah, that's right. We have perinatal palliative care programs across the United States. We're starting to build ours out here at Stanford. And this is where we look at high risk maternal fetal medicine. And we partner with our OB colleagues, with our neonatology colleagues. And we think about creating birth plans all the way up through young adults and patients in their 20s. And so it is a group of patients when you're thinking about all the different developmental needs, all the different needs as a whole. And if you imagine that many of these families are quite young, these are many of them first-time parents, and they may be themselves in their 20s. And so it's a really interesting field to be in because you certainly are working with these precious patients, but you're also working with their families. And this is a family under tremendous distress, tremendous stress overall, given this serious illness. And we have to think about how we can best support them because the unit of care that we think about is really at the family level, not simply at that patient level. Very different than how we think about care in the adult setting.
And let me just also, my brain is asking, so disease specific versus say an accident. So does your team really just focus on terminal diseases versus a long-term accident that might have led the child to be disabled or incapacitated?
Yeah, so usually we are involved with patients who have serious illnesses, and those illnesses are not usually traumatic in nature. However, there are significant traumas that then come about where there could be things like serious neurologic insults or severe neurologic impairment that comes as a result of that and need for I'm air quoting need for
Hmm.
technology interventions such as a home ventilator and a tracheostomy or a G tube and otherwise. And so as families are contemplating those kinds of decisions, our team might get involved with them to help in those particular situations, or for patients who have serious trauma and then have to transition to the home setting, but have really significant impairment, such as a severe neurologic injury, we might be involved in those patients' care. But mostly we take care of children who have serious illnesses. Easier ones to think about are congenital heart disease. We actually work with many different patients with lots and lots of different genetic disorders or neurologic conditions, or with children with cancer. So it's a real variety of illnesses that we work with.
So again, the reason I brought you on is because people just aren't associating death and dying, incapacitation with this population, we're saying under 21. So how can we start opening it up? Because I feel like by not having, hey, life is going to happen and kind of preparing people, when that moment of death does come, I could see how families would have a harder time going through the bereavement process because they didn't prepare, because they those words wouldn't come out of their mouth like my child's going to die, and because they don't have those words when the child does pass, that bereavement that grief process just lasts longer. So how can we as a society, and maybe you have some comparison of other countries that might be doing it, I don't want to say better, but maybe a little different, that gives us some insight?
Yeah, we actually know for sure that the more prepared a family feels, or if a family feels like things are going as expected and they're not either surprised or they don't experience a difficult moment at their child's death, that their grief and bereavement outcomes are improved. What I will tell you is it's very hard to figure out how do we help a family feel prepared, or how do we best alleviate this sense that there was a difficult moment at the time of death. There's lots of studies going on now to try to address those issues, but pain and symptom management expertise, which we bring to the table, can be helpful. Advanced communication techniques and things like conflict management and really working through things from this holistic point of view that I've been addressing with you, and trying to engage palliative care sooner in the illness trajectory. All of these things can really be helpful, not only in the moment that a patient is progressing towards end of life, but also in the grief and bereavement of the family. And you can imagine also the siblings are really struggling. And so it's one of those things when our team can come alongside teams like the child life specialists and teams like other psychologists to help support the siblings as well. And it's pretty clear now. The literature is not crystal clear because it's not in some sort of randomized controlled trial, but it's pretty clear that the more psychosocial and palliative care related support that patients and families, families as a whole do better in their grief and bereavement period. What I will tell you is that even if palliative care is involved, families still can certainly struggle during their grief and bereavement period. And so this is why it's so important to also have a very strong grief and bereavement program and a team that hopefully is even meeting the family before the child dies, and really then carrying that care through that grief and bereavement period, which can be very prolonged in pediatrics.
I mean, then the question is, are the other clinicians, like, how closely do they work with your team? Are they coming to you late? Do you wish that they would come to you a little sooner to start opening those conversations with the family, knowing that, not losing hope, because people don't want to lose hope. That's probably why they don't want to talk about it. But at the same time, having that realistic, maybe you should have that conversation with Dr. Baker.
Yeah, so I'm so thankful here at Stanford. People have welcomed us with open arms, and they're asking us to get involved in too many patients, to be honest. We have to kind of help guide and prioritize, because even though our team is big and growing, we can't see every single patient here. There's no way to do it. We don't have the capacity. And so we're very grateful that we get to partner with our colleagues in the Heart Center, for instance, and think with them, what are the highest patients and what are their priority needs, and how can we make sure that we're integrated at an appropriate time with them. And so what we're thinking about is, in particular patient populations, who should we just be a part of that team with them? And I would hope that we could do this more and more, but it really takes significant investment in order to be able to do that, because we're not only talking about the Heart Center, we're talking about the Cancer Center, we're talking about the Neonatal Center and Perinatal Center, we're talking about neurology, we're talking about surgical centers. And it's very complicated to be integrated as a part of the team into all of these areas where you're just kind of a part of standard of care. And at the same time, I really think that that's going to be a helpful approach for us to take with particular patient populations. For kids with high-risk cancer, for instance, integration with palliative care right from the point of diagnosis makes a lot of sense, where it's this co-management where we're working hand in hand with the oncology team. And our oncology team here, for instance, is really fully embracing that, and we're starting to implement that now. And so I think that that's the approach that we're hoping to take going forward. Right now, we still are mostly a consult-based service where people basically see that a patient and family is really struggling and they call us and ask us for a consult, and then we partner with them in longitudinal care. But what we really try to do is we always try to work hand in hand with that primary team, because we will never become a medical home for these patients and families. What we do is we really try to consult into their hopefully strong medical home, where we can empower the relationship that also exists there.
And that's the word, empowering, right? That educational piece to allow them to know that, A, they're not alone, they have the support, but there is that educational learning curve that they need to come to terms with. Like,
right.
Saying the word palliative, knowing when to access that service. And then it's, as you said, quality of life. When does that quality of life start to make more decisions?
And you
like I said, this is
concept of hope. And what we also have to help people realize is patients and families have many different hopes. Certainly a hope for a cure or a hope to live as long as possible. That's a very common hope. But there are additional hopes. It might be hope to be at home for as long as possible, or it might be hope to take a special trip. It might be hope, but we're always talking about hopes. It might be hope. You brought up the word normal before. Hope to live as normal as possible for as long as possible. It might be hope to get back to school or to get to have a party with friends. And so we're constantly talking about hope and trying to affirm hope and lift up hope in these patients and families' lives. We just try to help them hope for things that we can actually begin to work towards and accomplish.
And with that, do you have some additional like takeaways people can really start thinking about, knowing that this pediatric population should not be ignored when we're having these death and dying conversations?
Yeah, well, thank you for that question. I think the first thing I want to remind people is about the koala. You can see we have multiple koalas all around. And the koala you see is QOLA. It stands for quality of life for all. So who do we want to withhold quality of life from? Nobody. So when you think about your patients with serious illness, these children that have really complex diseases, we should be thinking about how do we best enhance their quality of life. And we do that by involving palliative care. Palliative care needs to be also provided by an interdisciplinary team. So this is another takeaway. We can't do palliative care as only a physician or nurse practitioner. We have to think about it with our social work colleagues, our psychologists, child life specialists. We have to think about it from a nursing perspective, a home care team perspective. We need to really think again holistically about concepts of suffering and how can we best attend to suffering and promote quality of life. I'd also say that it's really important to remember that we're helping a patient and family, especially that family, write that grief and bereavement story right from the point that we meet them. Meaning all of the memories that we help them create, all of the legacy that we're helping them develop in those last months or last years of life are things that are going to live on with them in their grief and bereavement period. And so this is a really vital time to make sure that we're integrating as many resources as we possibly can to support this patient and family, regardless of what their goals are. They may have a goal of living as long as possible, or they may have a goal of comfort at the end of life. It's really essential that we integrate interdisciplinary palliative care regardless of that goal.
And it's based on their personal beliefs, and that belief is going to come based on their family and life experience.
Yeah, and sometimes we also have to help families realize that what they are hoping for as far as their goals are, that there's some complexity in that. Like maybe that's not a realistic option. And so often we have to work with families and help support them in making decisions that they think are only bad decisions. You're forced between two options you wish you didn't have. And it's very common that we have to help them decide on the least bad decision, not a decision they would want to make. In fact, there was a really incredible video created many years ago, almost 2 decades ago now, called Making Every Moment Count. And there was a little child with a brain tumor in that video. And she said, "I feel like I'm stuck in a donut. No matter which direction I turn, I'm facing a decision I don't want to make." And so many of these families feel like they're stuck. And it's our job to be with them, to accompany them during these really complex times.
Such a special population. I mean, profession, like I said, so honorable. And at the same time, it's a calling. It's not for everybody. So thank you so much for sharing your expertise. And not just that, but the community, even just coming on to this podcast is letting people know that there's a message that we need to understand. This is the life is indiscriminate. So let's honor those that are here with us today.
Yes, thank you so much for this opportunity also, because it's through moments like this that we're able to advocate for pediatric palliative care support, because right now so many people are ignorant even that children get serious illnesses and die. And so I'm very grateful that we get to be on this together and talk about this really important topic.
Thank you. And if people wanted to reach out to you or learn more about your program?
Yes. So first I did a TED Talk also. So I think that would be something they could look up. They could look up Justin Baker TEDx, and they'll see that and they'll learn a lot more. We also have a vibrant website. If you look up Stanford Pediatric Palliative Care and Quality of Life Care, you'll see us there. Or you can just Google my name and Stanford, Justin Baker and Stanford, and you'll see a bunch of our resources there.
And with that, thank you so much for joining me, and we'll end our call here. Until next time.
Have a great day now.
Thank you for listening to the Digital Legacy Podcast, where we talk about death and dying in the digital age. I hope this conversation inspired you to take control and plan for the inevitable to protect yourself and those you leave behind. Don't forget to subscribe to our newsletter at digitallegacypodcast.com. Remember, life is full of surprises. What happens after you die shouldn't be. So keep your passwords safe and your playbook up to date.